Welcome again. Well, welcome again, and good morning. I invite you to settle yourselves, take a deep breath, and focus on why you're here today. And silently, we give thanks for our lives and all that we have. And so this morning, we are being joined by the lovely Dr. Indira Minus-Grimes. And I will go ahead and start introducing her while the rest of the meeting jumps in. Dr. Indira Minus-Grimes is a family medicine and gerontology specialist. She completed her training in both areas with the University of the West Indies in 2013 and 2018, respectively. She further completed a certificate in geriatric psychiatry in 2021 with the Canadian Academy of Geriatric Psychiatry. She currently serves as the Director of Services and consultant at the Geriatric Hospital at the Sandilands Rehabilitation Center. Dr. Grimes is a member of a number of national organizations that are working to remodel health and social care delivery to older persons in the Bahamas, including the Bahamas Alzheimer's Association, the National Older Persons Health Strategic Plan under the Ministry of Health, and the Older Persons Bill Committee under the Ministry of Social Services. Whenever she is not advocating for older persons, she enjoys family quality time and tending to her chickens. So if you're looking for eggs, maybe you could try and convince her to give you some. She is married to Dr. Valentine Grimes and is the proud mother of two children, Luke and Isabel. And so it's our pleasure this morning. And we say thank you very much to her for taking time out of her schedule to come and speak with us, Dr. Indira Minus-Grimes, who will be giving us an update on dementia and do a short recap. Welcome, Dr. Grimes.
Good morning. Thank you so much, Dr. Black, for that introduction. And thank you for the invitation to give a presentation this morning. So in the spirit, and good morning to everyone listening, thank you for listening. In the spirit of World Alzheimer's Month, and we are also on the threshold of celebrating International Older Persons Day, I will attempt to give an overview about dementia today, talk about its influences on the population, as well as discuss risk factors, causes, evaluation and management, and hopefully get into some developments for the way forward. So according to the Diagnostic and Statistical Manual of Mental Disorders, the 5th edition, dementia is a major neurocognitive disorder. It's an umbrella term for the syndrome in which there is cognitive decline in at least one cognitive domain, that is complex attention, executive functioning, language, learning, memory, perceptual, motor, and social cognition that interferes, and those cognitive declines or domain declines interfere with function or functionality. And the concerns may be raised by the patient, their caregiver or loved one, or an objective neurocognitive assessment. There's also minor cognitive disorders, and this is where mild cognitive impairment would fall. But in mild cognitive impairment, there's no interference with functional ability. So dementia is not to be mistaken or construed with normal aging changes of cognition. So normal aging, we find that it's okay to make a bad decision now and again, miss a monthly payment on a bill or forgetting where you put your keys, but there's usually a recall of what was forgotten shortly after. In Alzheimer's disease or dementia, what comes is the functionality changes along with the cognitive decline. So it leads to poor judgments and decision-making, consistent issues with maintaining executive function, trouble with communicating, and it often leads to effects on relationships as well. So dementia is typically described as a disease of later life, later onset. However, we have been seeing more early onset cases, and this is becoming more and more prominent. Currently, worldwide, 55 million persons are living with dementia, and 60% of them live in low to mid-income countries. And every year, there are 10 million new cases globally. It has a predilection for females, and the prevalence increases quite significantly after the age of 60, and even more so in older ages after the age of 85. Vascular dementia was thought to be the second runner after Alzheimer's. Alzheimer's disease accounts for about 2/3 of the types of dementia, and then vascular dementia and dementia of Lewy bodies come up as close seconds in terms of the types. The other types include frontotemporal dementia, Parkinson's disease-related dementia, and others. So dementia is also a significant leading cause globally of death, and is a major cause of disability and dependency for older persons. In the Latin America and Caribbean areas, it is predicted that the numbers will triple in the next few decades in terms of those who will be diagnosed with dementia. So the proportionate increases there, and there also will be a concurrent increase as we age. So estimates of incidence of dementia depend heavily on age. A longitudinal cardiovascular health study, cognitive study, showed that 19 out of the 160 participants alive at the age of 93 remained free of mild cognitive impairment or dementia. And further, 24 longitudinal studies, age-specific dementia was demonstrated to range from 5 out of 1,000 persons in younger, older age groups, 65 to 70, but increased significantly to 60 to 80 persons out of 1,000 after the age of 85. And we see it here in this graph where above the age of 80, you see a significant rise in the incidence of dementia. And we are seeing dementia affect us in the Bahamas quite significantly as well. We have similar epidemiological pictures. We're seeing a prevalence rise in our specialty clinics. And according to the World Alzheimer's Report in 2023, there are estimated 2,000 persons in the Bahamas living with dementia diagnosis, and this will triple by 2000. It's predicted to triple in a few decades. The National Insurance Board has on the prescription plan donepezil, which is an anticholinesterase drug typically used for the treatment of dementias, particularly Alzheimer's disease. And over the years, since 2016, the use and prescribing of the drug has increased tremendously. And we see in 2016, it started off in single digits per month. 3 packs per month were prescribed or bought by pharmacies. And it has now gone into the triple digits, over 100 packs per month in the last couple of years. So this is significant in terms of the diagnosis and what we're seeing in the clients, in the clinics, and so on. It has a substantial economic impact. Dementia costs a lot of money. Globally, it's costing the world over $1 trillion to maintain. Particularly, most of the costs are attributable to the care provided by informal carers. There are some entities like Medicaid and Medicare that help with the cost, but many persons have to share the burden of this cost out of pocket. And women are disproportionately affected. Not only are they at higher risk of developing dementia, but they are also the likely persons to be the carers. So if they're not living with dementia, they may be caring for someone with dementia. And so this can take eventually quite a emotional and physical toll on persons, affecting their psychological and physical health. So the hallmark of dementia, particularly Alzheimer's disease, are neuropathic changes, diffuse neuritic plaques that form in the extracellular medium of the brain. And this is called the amyloid beta deposition. There are also neurofibrillary tangles. And then you have intracellular accumulation of these tau proteins as well. In vascular dementia, it's compounded by vascular disease and issues with circulation to the brain. In Lewy body dementia, we tend to see these alpha synuclein inclusion bodies, otherwise known as Lewy bodies. And then in frontotemporal dementia, they have these unique tau or ubiquitin proteins, and also hippocampal sclerosis. But all the dementias overlap in terms of other findings and inflammation. So while there are microscopic, unique findings that may help to distinguish each type, all of them have been shown to exhibit mechanisms of oxidative stress, neuroinflammation, oligemia, neurodegeneration, and blood-brain barrier permeability changes. They're all common to all types of dementia. And this has implications as well for medical management. The autosomal dominant Alzheimer's disease accounts for a relatively small portion, approximately 1% of the cases of Alzheimer's disease. But it does overlap with sporadic Alzheimer's disease. There are mutations in one of three genes, the APP, or the PS1 and PS2 presenilin proteins. Okay, so if there's mutations in any of these, it's been identified that the mutations are quite penetrant, and it implies that 100% of those who have these carriers can develop Alzheimer's disease sometime in their lifetime. Most commonly, this usually is seen in early onset disease. But the late onset disease, the apolipoprotein E is blamed. It's found on chromosome 19, and there are three alleles, the epsilon 2, 3, and 4. If any person has two of these alleles, then either 2 and 3 and 4 usually, then you have the greatest risk of developing dementia. But the ApoE2 is protective. It's found to be protective compared to 3 and 4. So the genetic component increases the risk of developing the disease, and also predicts early versus late onset. Now, there are some protective factors. If there's studies have shown that good blood pressure control, maintaining regular physical activity, cognitive training, and higher education tends to protect against developing cognitive impairment. But it is a disease, as mentioned before, of later life. So as we age, and there's more risk of developing the disease. If there's a family history, obviously, because of the genetic component. Race also plays a part. Studies have shown that persons of African American descent with a family history have a higher incidence than those of the Caucasian race. And we talked about the ApoE4 allele, and certain other mental health and head trauma issues can put one at risk. Lower education has been shown to be a risk factor. And then there are the modifiable risk factors like hypertension, high cholesterol, impaired glucose tolerance, and obesity. Environmental factors can also play a role, as well as some medications. But the acquired risk factors is where I'd like to focus here. because we have to bear in mind that these have been found to be most relevant in midlife. In a 2017 study, 1/3 of Alzheimer's disease cases worldwide were attributable to these modifiable risk factors. And in the Bahamas, we rank pretty high with the modifiable risk factors, and we've maintained our high ranking over the last decade or so, which has implications for this disease and the risk we put ourselves for this disease in the future. Alzheimer's disease also ranked in the top 10 of all-cause mortality in the Bahamas. It was number 9. COVID. Is COVID a risk factor for dementia? Well, it has been shown, studies have shown lately that respiratory COVID can induce inflammation such as cytokine elevation in the CSF and neuroinflammation, as well as loss of myelinated axons, which lead to this term or the symptoms of brain fog. Other longitudinal studies have shown that the incidence of developing dementia or cognitive impairment is at about 12% after a month post-discharge from hospitalization and treatment for COVID, and this was found in an average age population over 69 years. It has also been found to be a precipitating factor for those who already have cognitive impairment, as it accelerates the cognitive impairment. And the brain studies shown there's increased white matter insults, mimicking multiple sclerosis disease and small vessel disease. So when we see these patients, just as a reminder, it's very important to have a very comprehensive history taking, take their complaint seriously. Some patients may come and mention that they're concerned about their memory, or their loved one or caregiver might bring it up. And this is a time to take on the evaluation of it and do the testing. Sometimes the patient may only require reassurance, but other times you may pick up other problems that are going on that warrant further investigation and management. So you want to, of course, assess the risk factors that the patient may have and find out exactly when the concerns arose. Go as far back as you can to figure out when did changes happen. And the changes may not have started with memory loss. It may have started with behavioral changes, language changes. Sometimes the client themselves realizes the deterioration and may have stopped certain activities. Also, certain life-changing activities may have happened that help to bring the symptoms forward, such as a retirement, a death of a loved one, and so on. And so this gives you a timeline, because it's very important with regards to talking about planning and prognostic factors. Of course, your medical history, medication history, looking into substance use or abuse, and social matters are very important as you get your history. And then, of course, a head-to-toe physical examination, including neurological and mental exam, also assessing their functional status. And we see some of the types of cognitive screens we can use here. Remember, though, that language and education can affect the type of cognitive screen and the result you may obtain. So these are the common evaluations used. But of course, one can start off with a very quick screen of the mini-cog, and this entails the 3-word recall as well as a clock drawing test. And if this is abnormal, then one would want to get into a more comprehensive screening tool and other tests that may help you to determine the type of dementia happening, or the type of cognitive impairment that the person may be suffering from. But remember that the U.S. Preventative Services Task Force has not recommended routine screening of older persons, normal persons, for dementia using these tools. But it is recommended that one screen, go ahead and use a screening tool if there's a concern or if there's an observed impairment in cognition. And of course, the comprehensive lab panel, because there are reversible causes of cognitive impairment, and these can be found through your comprehensive lab panel, looking for changes in thyroid function, electrolyte balance. Sometimes we're diagnosing for the first time syphilis. So hence we would do things like the VDRL screen, HIV screen. And sometimes people find it very funny that we're doing it on an 80-year-old, but you'd be surprised some of the first-time diagnosis that comes out of this screen. Remember too that many older persons have had gaps in their care over time. They have not visited the doctor in a while, so they haven't had a checkup unless there's a problem that they need to go to the doctor for. And so a comprehensive screen like this sometimes, believe it or not, is the first time they're having it for a very long time. And all along the way as well, you would want to evaluate their functionality, their executive function, being able to manage money, manage their medications, go shopping, driving, traveling, doing their housekeeping, etc., and as well as their basic activities of daily living, feeding themselves, doing their baths, going to the toilet, and so on. You should ask very pointed questions on this to get an idea of their baseline level. And as they're treated for cognitive impairment, if that is found, then you'd want to monitor their functionality along the way. And so neuroimaging is important. Sometimes you don't see very much on changes on the imaging, except maybe cerebral atrophy, but it's still very important because you want to rule out any other organic cause of their cognitive decline, such as a focal lesion, a new a CVA, any intracranial hemorrhage, especially if there's a subdural bleed. This can happen because symptoms can come up weeks later. If there's other indications for neuroimaging, of course, if the onset of cognitive decline is younger than 65, if the symptoms are sudden or progress very rapidly, if there's any focal neurological deficits on examination, if you suspect that this could be a picture of NPH, or if there's any history of trauma, very important, absolutely important to do your brain imaging. And you may start off with a plain CT, but an MRI brain is more specific without contrast and can provide more information on the brain volume, specific areas of atrophy, for instance, if it's in the hippocampus or not. And the PET CT, while that's not recommended as a routine test, one may use it to differentiate the type of dementia that could be occurring. And the PET scans usually can differentiate types of dementia through the type of metabolism happening in the brain and the glucose uptake. So differential diagnosis. So some people may present with concerns about cognitive impairment, but you may determine after your evaluation that this is in keeping with normal aging, or there may be mild neurocognitive impairment, or it might be a type of dementia. But bear in mind too that delirium and depression should be on the differential and ruled out. And there's a continuum with cognitive impairment, and people fluctuate between the two. So you have those who are not obviously cognitively impaired, or they may have MCI, and this is and the main feature here is there's no interference in their activities of daily living. But you get into mild dementia and so on when there's impairment in their activities of daily living, and there's two or more domains, cognitive domains, impaired as well. Studies have argued that everyone who eventuates into dementia passes through MCI. And so mild cognitive impairment is a big factor to pay attention to because it's a huge risk factor for progression into dementia. Now, some mild cognitive impairment may have a reversible cause, and we talked about evaluations for those. And of course, treatment may help the person's cognitive impairment to improve. Screening for depression is very important, and there are different continuums for depression as well. Older persons have a lot of life changes, loss of job, loss of loved one, loss of children in some cases, and loss of income. These all can put them in states of grief, and grief can become complicated. There is a diagnosis called complicated grief, and complicated grief could lead into depression and so on. Untreated, underdiagnosed depression can mimic dementia. And so screening for depression is very, very important, even if we're just doing it with a PHQ-2 in the office setting. And while drug treatments are not recommended and have not been found effective for mild cognitive impairment, it's important to at least recommend some non-pharmacological interventions very quickly and early with mild cognitive impairment. Alzheimer's disease is a gradual progressive onset, progressive decline in functioning. Motor sensory functions are usually spared until the late stages. Memory impairment is often the core symptom or the one thing that is recognized right away because it starts early. And so, but other things can develop later, like aphasia, apraxia, disorientation, visuospatial dysfunction, impaired judgment, and these come as the stages progress into the moderate and severe stages. And so the treatment is typically starting the cholinesterase inhibitors, particularly for your mild into severe stage. Vascular dementia may have a more stepwise progression rather than gradual and slow. The cognitive changes are similar to Alzheimer's, but on your imaging, you may see the signs of ischemia. And also there may be a strong history of risk factors for ischemic brain disease. And so the combination of the vascular history, the vascular insult history, and the changes in cognition usually put the person into this category. But the treatment is very similar as it is for Alzheimer's. So the dementia with Lewy bodies, for a diagnosis of dementia with Lewy bodies, both dementia and at least one of the following core features must be present. That is recurrent and detailed visual hallucinations. They're very vivid hallucinations, very real visions that the person is seeing and experiencing. Parkinsonian signs, fluctuations in levels of alertness and consciousness also can occur. And so the person also may have sleep disorders, sleep disturbances, and so on. And this disorder can be mistaken for a psychiatric disease like schizophrenia. And so because of the psychiatric component, the psychotic component in the disease. But the hallucinations usually come pretty early, even before memory impairment. And as I said, they're very vivid to the person, very disturbing to them. And as the disease progresses, they may develop Parkinsonian type symptoms, and hence the need for carbidopa and levodopa treatment. Frontotemporal dementia is the disease often seen in patients with onset of dementia in younger age groups. So early onset, and can be divided into three subtypes: behavioral variant frontotemporal dementia is characterized by prominent behavioral issues such as disinhibition, hyperaurality, lack of social awareness, and impulsivity. There's also semantic dementia, which manifests as impaired comprehension and impairment in fluent speech. Progressive non-fluent aphasia frontotemporal dementia presents with impairment in speech production. And so this type of dementia, first of all, should be considered at the top of the list for an early onset type. And notice that the behavioral and speech components are more prominent in this type of dementia than all the others, and quite early in terms of occurrences and decline. Now, delirium is something that sometimes is overlooked and forgotten. We should be aware of delirium, and it can be mistaken for dementia, especially when patients present in acute settings or when they're hospitalized. So delirium is an acute onset. There are fluctuations in cognition throughout the course of the day. Sometimes it's worse at night, and could be confused with sundowning and dementia. There's impaired consciousness as well. So there's fluctuating levels of alertness and altered sleep cycles. And delirium can persist for days, weeks, or even months if not resolved completely. And there's usually an underlying cause. So treatment of the underlying cause usually helps the delirium to improve. However, if the delirium persists untreated, it does put the person at risk of developing dementia or worsening underlying dementia or cognitive impairment. And as mentioned before, depression is very important to distinguish. Dementia is a more gradual process in terms of the decline. Depression has a shorter onset, shorter and more rapid decline. But the person usually has, and symptoms can overlap between dementia and depression. So sometimes it's hard to tell which one is happening. Maybe it's both, or which one came first, the depression, the chicken or the egg, the depression or the dementia, and brought on the other problem. But patients with primary depression are generally different from those with dementia in that they lack motivation. They express their cognitive complaints more, and they usually maintain their language and motor skills quite fine. But they have the disinterest, they have the social withdrawal, they have poor concentration, they often seem disinterested. The anhedonia is quite apparent. And using the geriatric depression scale tends to bring out more of the answers that you're looking for that may point toward depression versus using the PHQ-9 or other depression screening tools, because the questions circumvent asking, are you sad or depressed, but more ask about satisfaction with life, if they feel like life is worth living, if there's hopelessness, helplessness, worthlessness. And so that helps to bring out some of the symptoms that may indicate depression. And usually with treatment of the depression, the cognitive impairment improves. So the primary goal of managing a patient with dementia is to enhance their quality of life and improve their functionality, recognize any acute changes, and try to mitigate that as quickly as possible, and also deal with any acute medical problems that may be underlying as well. And so non-pharmacological management is always ideal before choosing medication, or it might be a combination of both. In 2012, a Cochrane review of randomized clinical trials showed a benefit of cognitive stimulation in patients with mild to moderate dementia. And a meta-analysis of 6 trials done in 2017 showed that cognitive stimulation with or without cognitive training did show moderate improvement in global functioning for people with mild cognitive impairment and or dementia over 6 to 12 months. The US National Academy of Medicine endorses exercise as a mode of prevention of dementia. And of course, family and caregiver support is very important to safety monitoring, etc. Knowing when to advise about driving or changes in other activities at home is also important as you monitor the patient. So I just wanted to slip in here, as it was sort of requested before, to just mention and emphasize the point about exercise. So for my DM research, I conducted a study on the impact of exercise on cognitive function in the elderly in New Providence, or attempted to do it, with the hypothesis that regular exercise would have a positive impact on their cognition and ultimately their functional capacity. And so it was an attempt at a clinical trial, mixed factorial design, and we pulled patients who were over 65. We randomized clients out of the geriatric outpatient clinics at Foxhill and Anstown, as well as the family medicine clinic. And so 77 clients were assessed and 25 had to be excluded. Some refused to participate. We ended up with 47 who were randomized into a non-exercise group or control group, and those in an exercise group. Some discontinued along the way, some were lost to follow-up. But ultimately, despite our small sample size, we did find over 12 weeks a positive change and improvement in cognition and overall functionality of those clients who participated in the exercise group over those in the non-exercise group. And so I think I just wanted to put that in there as a small endorsement for how exercise, a non-pharmacological intervention, and regular exercise, because these persons did walking on a treadmill, use of a stationary bike, and they came 3 days a week and exercised for a minimum of 30 minutes. And we also saw improvements in their blood pressure and heart rate, as well as their overall social happiness, because they use the get together to exercise as a social outlet as well. So environmental modification is very important for dementia clients. Making sure there's clocks and calendars. It may be clocks, digital clocks in large writing, showing the date, showing the time. Maybe the clock will talk to them and tell them today is, and so on. Reminders around the home, names of items. This is the bathroom. This is the back door. Things like that, signs with colors and so on, to help people to be as independent as possible in their personal environment, to take walks, participate in gardening, manage pets, and do things around the house. Many of persons decline as they lose purpose, as if the more we put them in the corner and say, sit there and I'll do everything for you, the less they will do, but also the faster their decline. So sometimes pharmacological management is absolutely necessary. The current FDA-approved medications for Alzheimer's disease include the cholinesterase inhibitors like donepezil, rivastigmine, galantamine. And then we also have the monoclonal antibodies recently developed, memantine, other cognitive enhancers. Of course, antidepressants and psychoactive medications may be necessary as the disease progresses. So the cholinesterase inhibitors break down acetylcholine, and they help with delaying cognitive decline. They do not reverse the cognitive decline. They may help with the behavioral problems. Sometimes other medications may be more help in an adjunctive way. But we have to be mindful of their GI side effects. particularly if they're taken with food. Persons tend to get nausea, vomiting, even syncopal side effects. And so what I find is if it's taken more in the afternoon, between lunch and dinner, and not quite with the food itself, that it's better tolerated. High doses definitely put them at a higher risk of the side effects occurring. In vascular dementia, the acetylcholinesterase inhibitors are not recommended. The treatments that the studies, the research is showing should be focused on enhancing brain circulation. But there are times where patients do respond to the cholinesterase inhibitors as well, or another type of dementia drug as a part of the treatment in vascular dementia. Because of the attention and behavioral disturbance in Lewy body dementia, sometimes the cholinesterase inhibitors can help, as well as patients may benefit in Parkinson's type dementia from rivastigmine, but it can worsen the sequelae in frontotemporal dementia. Memantine helps to protect against excitotoxicity and neural injury in the brain that occurs with the pathology that causes dementia. It may not have very much benefit in Alzheimer's disease, but it has been approved more for your moderate to severe for early Alzheimer's disease. It's not so beneficial, but has been shown to benefit those with moderate to severe Alzheimer's, may be effective also in vascular dementia, but it again, like the others, has its side effects that we must be aware of. So the newer guys on the scene are these multi-syllable drugs that may not be easy to pronounce, but they are said to slow the disease progression by binding and removing protein from the brain, the protein called amyloid beta. And in June 2021, aducanumab was brought out in an accelerated way by the FDA. Now, this is the first one approved, and it targets beta amyloid in terms of decreasing and modifying the disease pathophysiology. It's very costly, and there's controversy surrounding its approval, its accelerated approval, because while it might demonstrate the beta amyloid plaque distribution reduction on PET-CT, the clinical correlation hasn't been seen with that reduction on the PET-CT, and then the side effects are quite significant in terms of the brain edema, headache, confusion, and diarrhea. Lecanemab just came out in July 2023. This received a traditional approval. It's a humanized IgG1 monoclonal antibody that binds to these high affinity amyloid beta soluble protofibrils. So it reduces the amyloid markers and said to decrease decline in cognition measured after 18 months. We have donanemab, which also came out about 2 weeks after the FDA approval of lecanemab. And this showed similar findings to the lecanemab, but it's awaiting FDA approval. And then you have solanezumab, which targets monomeric amyloid, but it hasn't shown benefit to cognitive decline after 240 weeks of treatment. So it is not something that is being endorsed, nor the others listed, because trials were either shut down due to failure of the drug showing any benefit. The challenges with these newer drugs are that they have significant side effects. Trials have shown that they can be fatal in terms of causing these microhemorrhages in the brain. It's been shown in the 3% of cases in the lecanemab phase 3 trial, and it requires testing for the ApoE allele before treatment, and genetic testing isn't readily available. Arguments that it's not really disease modifying are coming up. Researchers are saying, what if the plaques aren't really the only cause of the disease? So when we decrease the plaques in the brain, are we really making a difference to slow the disease progression? Remember now that in the pathophysiology, oxidative stress, cytokine formation, inflammation, hypoxemia, all of these have contributed to the disease progression as well. And so once we've decreased the plaques, even though we're not sure exactly where those plaques came from and how they got in the brain, then how do we address the inflammation, and does it really slow the progression, or do they just show a short improvement because of the decrease in the proteins, and then it progresses on because of the other pathological features? These drugs are very expensive. Lecanemab is cost, even with even though Medicare can in the States can supplement 26 grand a year, and even some people with insurance have to pay a copay of up to $14 per day for the drug. And then studies were a bit disproportionate in reporting its effect on women. So lecanemab, did slow the progression of decline in 27%. But when they disaggregated it for men and women, the effect was better in men than in women. And this may be because there weren't enough women in the study, or is it that women weren't responding to it as well as men? So that is to be answered by further study. The infusions also require a multidisciplinary team to be around, including a behavioral neurologist, neuropsychologist, and neuroradiologist. So how practical would that be in other centers where these specialists are not readily available? So there are cognitive enhancers like vitamin E, selegiline. They may lower the rate of functional and cognitive decline. Ginkgo biloba studies have shown there's no real benefit to helping with cognitive decline. Psychoactive medications may be necessary to manage psychiatric symptoms such as hallucinations, but non-pharmacological management is also helpful through physical activity. Touch therapy, music therapy has helped to calm these behavioral symptoms. Antidepressants may be necessary to address depressed mood, insomnia, fatigue, irritability, agitation. A systemic review showed that sertraline and citalopram were quite efficacious with agitated behavior in dementia. And so these medications could be considered, but remember that there are some antidepressants that can worsen anticholinergic effects, and also especially in combination with the anticholinesterase inhibitors like Paxil. So mood stabilizers like valproic acid, Tegretol, these things can help, but there's limited evidence on how much they can help and how long we should be treating with them. We should avoid benzodiazepines and anticholinergic medications, which may worsen symptoms or cause rebound symptoms if the treatment is stopped. So when we see these patients, we shouldn't just focus on the dementia. Remember that we are trying to improve overall quality of life. So we want to avoid communicable diseases, infections, optimize their nutrition, avoid wounds and trauma and falls and so on. Refer them for dental care, optimize their vision and hearing as best as possible, and offer preventative medicine as well in terms of vaccinations, etc., to prevent any other health issues and hospitalization, unnecessary hospitalization. Treatment of dementia is multidisciplinary. Okay, there's no one person who could treat one dementia case. It really takes a team because it is exhaustive. It's you're not only treating the client, but you're also attending to their caregivers and trying to give the best holistic care you possibly can during this time to the client as they go through this very terrible disorder. So a geriatric psychiatrist, neurologist, neuropsychologist, referring to specialized clinics for symptoms to be managed or just getting consultation, just bringing in extra team members is also great. Social workers are very helpful. We need to increase our case managers for older persons because they help us look at the social care of the patient, the home environment, the environmental factors that play a big role into the care of the client. And also they help to reduce how much the client is seen in hospital and in the clinic in terms of making sure that that environment at home is conducive to what they're going through with the disease. Physical therapy, occupational therapy, and recreational therapy are all very important if we can refer to them to get their optimized on their activity and vocational activity, extremely important. Sometimes nursing services, even to refer nursing services at home, community nursing, very important, and getting the pharmacists involved in terms of managing medications, ensuring that we're reconciling medications to avoid drug-drug interactions. Sometimes medications also have to be compounded in different forms, placed in liquid form and so on, because the patient is not swallowing tablets anymore, or it's difficult to get them to swallow something solid. So the pharmacist is very important. And having a regular pharmacist with that client is very important because patients and their caregivers often get mixed up with meds, ask for refills before refills are needed. And you want to avoid people overtaking medications as well. So the pharmacist's help is important. Because the disease progresses and eventually, the person becomes totally dependent for care in every aspect of all their basic activities of living, legal matters should be addressed and should be addressed early once the diagnosis is confirmed. Caregivers, families, and of course the patient should be aware that advanced planning is important, and the patient, as long as they can make decisions for themselves, ought to be allowed to do so and should try to do so and put it in writing as soon as possible so that their wishes are carried out when they are no longer able to communicate them. And bringing in community is important and support. Some persons may need the help of adult daycare, respite care, and other assisted living avenues to deal with the challenges of caring for someone with Alzheimer's disease or any type of dementia. And then there are other organizations and entities that can help with cost of supplies, education, as well as legislation and so on. Because as mentioned earlier, this is a very costly disease, very comprehensive, complex disease that once the person deteriorates, they need help with everything. So we get inundated with requests for letters for, to help with the cost of diapers, food, wheelchairs, hospital beds, etc. So, as we move into the future, and we know that our numbers are going to increase based on quotes given earlier and predictions given earlier, not only worldwide, but for this country as well. So we should be advocating for the care to come, or the care that we actually need now and we will need in the future, like memory care units, and optimizing training for care providers, not only professional, but informal carers as well. We need to streamline the healthcare avenues so that patients and their caregivers know where to find care, how to get it in a timely fashion, and we should have specialized units whether it be in the inpatient facilities or in the community. We should advocate for a national dementia plan. Countries are being asked and pressured to some extent to be able to publish a national dementia plan and what we're going to do, what are we doing healthcare-wise, social-wise for these clients, and how are we funding it, and how are we legislating to advocate for these persons and older persons in general. The caregivers need our help because the caregiver burden is high, very high. And so we need to encourage, as healthcare professionals, our caregivers to try to have a positive attitude toward caregiving. It's very stressful, but if we emphasize to them the good thing about caregiving, the love and the hope that they should have through their caregiving, that's very important, that they should set goals, that they should make plans, that they should include the person they're caring for in those plans where possible, that they should manage their time well and take breaks where possible, bring other team members in who can help them and get professional help when they need it, and also encourage them to maintain good health for themselves, because if they're not healthy, they can't take care of the persons they're caring for. As healthcare providers, we should choose wisely not to put these patients through unnecessary genetic testing unless we're doing research of some kind or they're entering some kind of trial where we want to kind of get an idea of the disease progression they may be at risk for, avoid expensive imaging. So PET CTs aren't necessary. If the patient can't afford an MRI, great, but a CT brain is adequate. Don't use all the medications in dementia on everyone. Some medications work for some and some don't work at all. Some of them worsen the symptoms, worsen the progression, and so we should back off where
Can't hear you. You are muted.
Sorry. I'm sorry. I don't know when I got muted. I apologize.
Maybe 30 seconds ago.
Okay, so what this slide just shows some of the things as healthcare providers we should not do or race to do. We should avoid genetic testing or expensive imaging. A CT brain is fine, MRI if the patients can afford it, but a PET CT is not necessary. Gene testing is not necessary unless we're monitoring through research or looking at or really need to know if they have this increased risk for disease progression. Do not routinely prescribe medications, especially if the patient is sensitive to the side effects or if they don't provide any cognitive benefits. Emphasize general healthy living. Anticipatory guidance is important, just as it is for the pediatric population. So encouraging persons to plan and put things in writing for the wishes in the future is very important. Occupational living and anticipation is important, avoiding falls, avoiding injuries. Like I mentioned, their vision and hearing assessments and so on, all is important because ultimately all you want to do is keep them as independent and functional as possible for as long as possible in the safest possible way, and avoid peg feeding if possible. Of course, careful hand feeding is always recommended for as long as it can be tolerated. So dementia, in summary, is not an inherent part of aging. It is not normal to dote. It is something that we should take seriously and listen to concerns when voiced, screen and treat early where possible, and also do your comprehensive history and evaluation to look for reversible causes and treat. When faced with imparting the diagnosis of dementia, I think we should be encouraged to tell the truth, to be as plain and simple when we're giving the information. We should have supporting persons around when we're giving the clients the information, but also ask the client if they want persons present to hear the news, and it should be someone they trust. Coordinate with the caregivers and explain the purpose of testing, what the expectations of the disease are, provide education as much as possible about how to live with the disease and care for it, and treat where necessary with medications, and pull on community resources to support not only you as the healthcare provider, but the patient, of course, and their caregivers. These are my references, and I thank you for listening.
Thank you very, very much for that really excellent and informative overview and presentation, and especially in this week of dementia awareness for September of 2023. You did present a lot of worrying information in that dementia is carded to triple in the next few years, and highlighting that we have a lot of the acquired reasons for dementia. We do have a couple questions for you. Very informative discussion. Can you elaborate more on the relationship between, hold on. Can you elaborate more on the relationship between dementia and the lack of sleep, and the prolonged use of screens has a role in the increase and early onset?
Okay, so thank you for that question. Excellent question. So yes, sleep deficit has been found to be a risk factor for dementia or cognitive impairment. So persons with the lack of sleep, there is the sleep time is the time for the brain to detoxify itself. So less sleep, especially less REM sleep, does not allow the brain to properly get rid of inflammatory problems that may have occurred during the day and insults and so on. So it's a detoxification time. So if these toxins build up over time as a result of lack of sleep or sleep deficits, sleep disorders, then ultimately this can cause the inflammatory insults mentioned before that can put one at risk of cognitive impairment. I'm not sure I understood the second part of the question, screenings for early to late disease.
Okay, so what we can do is we can ask the person who wrote the question to unmute while you answer another question, and then they could clarify that for you. Our next question, what's the impact of co-occurring substance abuse disorder on the prognosis of dementia in the elderly? 1. And 2, does dementia increase the risk of suicide in the elderly? And do you have any data from the Caribbean?
The co-occurring substance, well, substance abuse would increase the risk of any brain dysfunction, particularly if the blood-brain barrier and permeability is impaired. And you can find this especially with vascular diseases and so on. So of course, if the toxin, affects the brain, then naturally cognitive impairment, the risk of cognitive impairment increases. And what's the second part of that question, Dr. Black? Sorry.
Does it increase? That's okay. Does it increase the risk of suicide in the Caribbean, dementia? And do we have any statistics for the Caribbean?
Unfortunately, I am not aware of any statistics for the Caribbean for dementia and suicide. Yes, it can increase the risk of suicide, but I could not give you any hard data facts on that right at this time. And I have not come across anything in the Caribbean on that particular subject. Sorry.
Okay. And does multitasking have any role in the onset of dementia?
Not that I'm aware of. I'm certainly persons who have higher education, higher skills and abilities. It tends to be more of a protective factor, I believe. But I haven't heard of it being something that can accelerate the onset. And even more so, it's, one of those, people being functional and task oriented, having purposeful tasks is helpful in also slowing the decline.
Okay, thank you very much. I mean, I know we are at 9 o'clock and we understand if, some individuals have to leave, but I want to finish up the questions because there's still a couple questions for you, and it really was an excellent presentation. What strategies can this nation have in place to aid in the reduction of dementia?
Great question. First of all, education. We need to do more public education on dementia to reduce the stigma, to reduce the fear of persons coming forward if they have concerns and being evaluated so that the problem is recognized early and treated early. And then we also need to enhance or strengthen entities that can support persons going through dementia, but at the same time empower them. So we need to find ways to keep them well integrated in society and in the community, so they don't feel marginalized and hidden away from society. I think these are some of the things nationally we can do. And once we see that happen, then we can get more from on the healthcare and social side in terms of helping these persons and their caregivers as they go through the disease progression. So legislation also would help that as well. Thanks.
Thank you. And we have fantastic presentation. Does occupational therapy help at all?
Absolutely. Absolutely. Occupational health therapy would help a great deal. So I mentioned that the rehab therapies, I know I only had physical therapy on the screen, but occupational therapy and recreational therapists are all very vital in the management of dementia clients because some of them can be retaught how to do basic functioning, like feeding themselves, like brushing their hair, like buttoning their blouse again. And these tasks might seem minor, but just getting them to do these things helps to improve their dignity, their mood, and their sense of purpose. And this also can improve behavior. One of the pictures I showed on my slide is what occupational therapy is doing at Sandilands with our clients. They're doing efforts with painting. They do efforts with gardening, showing clients new things that they can do. And this helps to occupy their mind, these task-oriented type activities.
Thank you. Awesome presentation. Thank you for such a useful refresher and update. An excellent comprehensive presentation. And we have another question, which was a question I wanted to ask you as well. Have you seen an incidence of inherited dementias amongst families, mother, children, father, child? I know we don't do the genetic testing, but have you seen an incidence in certain families or in families?
Just by observation, the answer to that is yes. There are quite a few families that I've seen occurrences between siblings and parents and children with Alzheimer's, and some families will also share that information quite readily with you that, my aunt had it, my mother had it, my father had it, or my sister or brother. So we do have it. I don't have any hard data on it. We do need to do more research to get the facts and be able to quote incidence and prevalence.
Okay. And we have one final question for you, and then we will close the meeting off. Excellent presentation. Any proof that popular brain training games affect dementia's progress, like Sudoku, Luminosity, etc.?
Yes, brain games, cognitive, that's all a part of cognitive training. So yes, they do help to slow down the decline and help the patient's focus and concentration. And also, when you get the history about these clients, you should find out the kinds of activities they like to do or they were very good at when they were younger or before the onset of the cognitive impairment. Like if they were good at darts or playing cards or dominoes or good at a particular sport, you'd find that when you place them in an environment where they're able to do those things, the abilities come right back and they almost, without thinking about it, are able to do the activities and be very good at it. And it also, because of the mood component and behavioral component of dementia, these focus activities always help mood and agitation. They help to reduce it. So yes, the brain mind activities like those games are very helpful.
Okay, and I know I said no more questions, but I just have one last question that I am going to ask you. And so based on everything that you've said, knowing that the incidence is increasing, we have a lot of the acquired risk factors, should we as family practice physicians and internists be recommending a dementia prevention program at a certain age for our patients rather than wait for them to start having early dementia or scoring, less than 30 on the mini mental status exam? And at what
Excellent
age?
question. Yeah, thank you, Dr. Black. Excellent question. An excellent idea. We absolutely should be doing that. And again, this comes back to education and awareness, first of all, and then encouraging this as part of their reasons for their annual checkups and screenings, early and maintenance of good control of blood pressure, glucose management, and cholesterol. And weight, of course, because obesity also is a modifiable risk factor. So yes, I agree with all of that. Mhm.
Well, thank you very, very much, Dr.
Thank
Minus-Grimes.
you.
We
Thank you for
appreciate you
having
taking
me.
time out to come and join with us today and educate us. And thank you to you, our audience. Without you, this would not be possible. We have posted the feedback link in the chat. If you don't have it, the feedback link is also on the university website. You can complete the feedback link. There is a CME credit being awarded for this meeting. And for those of you that may not have been able to join from the beginning, the meeting has been recorded, so it will be placed on the University of the West Indies website. Thank you very much for joining, and everyone have a wonderful day.